A very good morning. So today we will start our program with a small prayer offered to Ma Saraswati, the goddess of learning.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा.
Thank you and welcome again to our program, teaching program at Department of Urology, SMS Medical College, Jaipur. So today in our teaching program, as a faculty talk, we have with us a very renowned personality, Dr. Mahendra Bhandari. Dr. Mahendra Bhandari is presently the CEO of Vatikutti Foundation. We are proud to have him also because he started his surgical career from our own department at SMS Medical College. And from there, he went to Jipmer Pondicherry, where he developed the Department of Urology, and later to SGPGI Lucknow, where again he developed the urology department and also the cadaveric transplant program in northern India. And then he also became the vice chancellor of the Lucknow University, and then he shifted to United States and joined the Vatikutti Foundation. Dr. Bhandari is not only a urologist, a kidney transplant surgeon, and robotic surgery specialist. He is a medical educator, innovator, and a health administrator. Dr. Bhandari has many special contributions to him, to urology, medical training, hospital administrations, and medical ethics. He has been on the boards of multiple journals and as the president of several medical societies. He has exerted a vast influence on the practice and teaching of medicine, especially the development of residency programs for the specialty of urology. And for his all these efforts, he was awarded one of the highest civilian awards in India, that is Padma Shri, by the government of India in the year 2000. He was also the symposium coordinator of the International Robotic Urology Symposium. Presently, Dr. Bhandari is the CEO of Vatikutti Foundation, Director, Robotic Surgery Education and Research, Vatikutti Urology Institute, Henry Ford Hospital, Detroit. So most welcome, Dr. Bhandari, to our platform of Department of Urology, SMS Medical College. And today, we have a special invitee with us to this faculty talk of Dr. Mahendra Bhandari, who is the CEO of Vatikutti Foundation, none other than the founder of Vatikutti himself, Dr. Mani Menon. So Dr. Mani Menon is the Rajendra and Padma Vatikutti Chair in Urologic Oncology at Henry Ford Health System. He is also the clinical professor of urology at Case Western Reserve University, University of Toledo, New York University Medical School, Wayne State University School of Medicine, and also a senior at surgery at Harvard University. He started his career and graduated from Jipmer Pondicherry, and then later joined John Hopkins Hospital and did his residency and fellowship with Dr. Patrick Walsh. And then he became the chairman and professor of the Division of Urologic and Transplantation Surgery at University of Massachusetts. And he was the youngest chairman in the country at that time. In 1997, he became chairman of the Department of Urology at Henry Ford Hospital and established the first cancer-oriented robotic programs in the world. In fact, he was the first to do a robotic radical prostatectomy in the United States. Since 2013, the Vatikutti Urology Institute technique of robotic kidney transplant has been successfully adopted at multiple institutions across the world. He is currently in the process of setting up a formal clinical trial for the precision prostatectomy approach to carcinoma prostate. Dr. Menon has been recipient of multiple awards. To name a few, the Gold Cystoscope Award of American Urological Association. In 2014, he was awarded the Hugh Hampton Young Award by AUA. In 2016, he was awarded the Case Medal, recognized as the greatest individual citation by the Genitourinary Surgery Association. And in 2008, he was awarded the highest medical professional award, Dr. B.C. Rai Award, from the President of India. He has been the visiting professor of more than 50 universities all over the world. And he has more than 1,000 peer-reviewed publications in the various journals. So welcome, Dr. Mani Menon, to this platform. We are really honored and proud to have you, both the living legends today, Dr. Mani Menon and Dr. Bhandari. So because Dr. Mani has to leave because of some urgent commitment, and so we will change our custom a little bit. I would invite first Dr. Mani Menon to give a brief comment or talk on his journey from establishing the robotic surgical program at the outset of the 21st century, that is nearly in 2000, to this point of time. So welcome, Dr. Mani Menon. Over to you.
Thank you, Dr. Priyadarshi, and I apologize because of a conflict in scheduling. I have 4 things going on at the same time, I have to go see patients. I'm winding down at Henry Ford, so these aren't patients I can put off for a period of time. I'll be going and to New York, joining one of Dr. Bhandari's residents, Ashutosh Tiwari, in his department at Mount Sinai. Much of my career has followed Mahend's footsteps, and we have been friends since 1983. So he could talk about me actually better than I can talk about myself. I saw him in 1983. I was a student at JIPMER. JIPMER didn't have a urology department. We had a general surgeon who, a very, very good teacher. My teacher was Dr. Budhraja from Delhi. He was a general surgeon who was doing urology. To my interest, he was the first person who talked about radiation therapy for the treatment of prostate cancer. You know, this was completely of academic interest because JIPMER at that time did not have a radiation therapy department, nor did we treat prostate cancer. And that was my entire exposure to urology. Simple prostatectomies is what we did, and complex open stone surgery. In 1983, I had risen in the academic ranks, and I had become a tenured associate professor. And much to my surprise and happiness, I got the letter from Washington University when I was in Dr. Bhandari's presence. He had organized a huge meeting for urethral stricture, and I couldn't attend the meeting because of travel commitments. But he said, come the day after the meeting and we'll sit down and talk. And I spent several hours in the presence of his family and him. And we've become fast friends since then. I think I visited him half a dozen times in JIPMER and at Sanjay Gandhi. He trusted me with his son, Akshay, who had finished medical school and then came and joined us first as a research fellow in the lab working on kidney stone disease, and then as a clinician. And you can see the genes in the family. Akshay is just a fine human being and a fine surgeon, and now is a professor of surgery at Mount Sinai Hospital in Miami. Akshay spent 11 years with me, and we succeeded in getting Mahendra Bhandari to come and join me. I'm not sure that I was the first person to do a robotic prostatectomy in the US. I may have, if you use that technically, in the sense that we did the operation from the beginning to the end. I think there was one case where a general surgeon and a urologist started doing it, and they did part of the cases robotically, and then they abandoned it. But we sat down and we created a program. A program is nothing if you don't know your data. And collecting the data is extraordinarily difficult and requires a labor of love. For the first 4 years, Ashutosh Tiwari was the resident, and he collected the data. But it was just one resident calling the patients, and this would not stand up to careful scrutiny in the literature. And I was uncomfortable about this, but I didn't know what to do about it. Collecting data was not that common in the United States. Records were not computerized in most places in the United States, not at Harvard, not at the Mayo Clinic, not at Hopkins. But they were computerized at Henry Ford Health System. So Dr. Bhandari came in, and I was greatly relieved to have him take over. You know, I didn't know much about computers then. I don't know much about computers now. But he, as you will see from this wonderful talk, he knows about these things. He's got a rare insight into the future, and he started our database. You'll know that at the end of today, we'll be submitting a paper on the first 20 years of robotic prostatectomy. And which is going to be done by another Indian resident of mine, Akshay Sood. So over a period of time, Dr. Bhandari and I got one well-intended reputation, and that is we created a good training program, and Henry Ford was a good place to train and become a surgeon. We also, quite unintentionally, created another image, and that is the only way you can be a good robotic surgeon is if you are from India and you come to Detroit and train. And I'm happy to tell you that's no longer the case. But it was kind of funny. You'd go to meetings and they'd say, "Oh, you know, this is of Indian origin. Of course, he's a great robotic surgeon." But we have trained some of the great robotic surgeons: Ashok Hemal, Alok Srivastava, Akshay Bhandari, Ketan Badani, and we've seen some non-Indian urologists too, like Danny Un, Khurshid Guru, and I may be missing some people because I'm speaking off the cuff. So it's been my privilege to work with Dr. Bhandari. It's been my privilege to help the field of Indian urology, particularly in robotics. Following along with Dr. Bhandari here, he took the lead in setting the programs. And it's an honor to share this podium with him and you. Good evening, and enjoy the rest of the presentations. I saw a preview on it, and it is absolutely fascinating. Thank you, Dr. Priyadarshi.
Thank you, sir. Would you like to say something about your recent, about that precision prostatectomy that you are working on? Brief comment.
I have felt that prostate cancer surgery has lagged behind breast cancer surgery in its sophistication. And other than the fact that we're using the robot, we're doing the same operation that was done in 1948. And that's not the field for breast cancer. Most breast cancers are not treated with mastectomies, but 25% are, but 75% are treated with breast-preserving surgery, the only purpose being cosmesis. So we thought maybe we could model prostate cancer and see, do we need to take out the entire prostate in everyone? Can we preserve the prostatic capsule in some patients? And if you preserve the prostatic capsule, you are going to have better nerve preservation and you'll have better urinary and sexual function. So Dr. Bhandari and I and Rajesh Alawat from Medanta, who was visiting us, we sat down and we brainstormed, and we found out that 80% of time, 80% of patients, there is a zone of the prostate, of the prostatic capsule, that can be preserved. The only way you know that there's no cancer there is by creating sophisticated biopsies. So if you biopsy that area, and if there's no cancer, you can preserve it, and the return of sexual function, particularly, and urinary function is dramatic. So that we called operation, we called precision prostatectomy. My original intention was to call it modified radical prostatectomy, which is an acronym for Mr. P. But I was told that I was being too frivolous, and precision prostatectomy is the term we would use. So we've done 5 years of that. Hope to do a randomized control trial, both at Henry Ford, at Sinai, and maybe in the UK. And then we'll see whether this, where the chips fall.
Thank you, sir. Actually, sir, your pioneering and the groundbreaking work has definitely changed the way urologists operate today. In fact, you, in your own words, married the traditional surgery and the computer-assisted technology to create a novel visionary modality through which patients receive not only equivalent but better outcomes. So today we know robotic surgery is so common, and more than 7 million robotic surgeries have been done in the world today since its inception. And almost 1 million robotic surgery are being done every year now. And this is probably your pioneering work, which has contributed a lot in this process. Thank you very much, sir. Thanks a lot for again sparing your valuable time here and giving us the opportunity. Thank you very much.
Thank you very much, Dr. Priyadarshi. Thanks, Mahendra. Take care. Bye.
Thank you. So now we know that urology has been at the forefront of various innovations and different surgical techniques. But we also know that digital technology has been growing exponentially. And where there are a few questions now put to the urological fraternity, that are we actually falling short of this revolution in the digital technology? Or do we need to change our whole culture of the current understanding of our data collection, analysis, and utilization? And what does the future hold for urology in terms of surgical automation, digital technology, and artificial intelligence? And to answer all these questions, we have today with us the CEO of Vatikutti Foundation, Dr. Mahendra Bhandari. So welcome, Dr. Mahendra Bhandari, sir. Thank you for sparing your valuable time, and over to you for your presentation.
Thank you, Shivam, for inviting me. Can you see my screen?
Yes, sir.
It's really honor for me. Not only you recognize me by inviting, but you put me into my down the memory lane 50 years, 48 years ago. It's nostalgia, because my foundation started with SMS Medical College. The bust which you showed was created through Dr. P.K. Sethi by one of his relatives when I was there. And let me tell you, I can see there are very few people who would know about the history, the present generation, because history is past and it doesn't matter for them, except for, I see the name of Madan Mohan Bansal, and partly you had been involved in it, and there may be few more. Besides learning medicine from my alma mater, I left SMS Medical College, a little correction, not for Zipmer, but for All India Institute to take a faculty position in 1977. And my toolkit was already complete with all cognitive and non-cognitive capabilities. I'll tell you how. I learned the best patient care and bedside manners from Professor Gangwal. Besides, he was the one who chose urology for me and who chose and make sure that I get admitted at CMC Vellore for the MCH program. I remember n number of days as his chief resident and lecturer when he will take the patients himself in his car for post-operative outing to Statue Circle. Very few would do. I never met in my 50 years anybody would do. Bring soup from his home to give to patients. And mind you, they were not always very influential patients. We were known as, always the colleagues would say your prostates are diamond studded because we would have VIPs too from all over, but he did that. So there could not be a better lesson of human side of medicine. I learned highest ethical standards from, I think it is more important than the actual talk, Shivam, so I would not curb myself to reveal these things. I learned the highest ethical standards from Senior Professor T.C. Gangwal. I used to visit Dr. Gangwal's house very often. And one day he met me near his Sulabh Nidan, which was right at the entry. And I said, sir, there is a lot of rush. I didn't know what I was going to have because he was very abrupt, no nonsense kind of person, those who know him. So he said, this is all because of you. If you people in the government hospital would work, I would be happy that all these private labs close. That was the biggest lesson of ethics for me. I had seniors like Professor S.C. Mathur, who would like to do every surgery and still they would be open to give you every surgery, and such a low level but high level of skill and emotional intelligence. I had my immediate senior like Dr. D.N. Kalla, excellent surgeon, and I picked up a lot from him. So I think SMS really was the foundation. Now, why I want to talk about digital urology? Because I feel that until really we know what are the winds flowing, it would be very unfortunate that we will not understand our own journals. And those of you remember, it happened in 90s with me when molecular biology and we were taught very little. That's why I thought I'll ring a bell that you should really consider what you call keeping an eye on what is in for the future. Can you see my slides?
Yes.
I'll repeat this.
Yes, sir.
And this is an open invitation to the participants, because one of the reasons for me is to excite some of you to get into the field. And I'll repeat this slide at the end with my email address, which is no secret. And anybody who wants to really get involved, I'll be very happy to support them. I have a funded project with my partners and partly by National Science Foundation. And I'm honorary advisor to Ready Minds, which is a private company which has done this wonderful software work, which we have on AI, which I'm going to share with you. I have no other financial interest to do. Though whatever may be title, I'll try to distract you by taking you through my journey, which is over 3.5 years or 4 years. But the focus would be on only one thing: predictability. And this emanates from my own experience, which some of you would relate, that surgery, even at the age of, at the close to 50 years of my sojourn with the surgery, is unpredictable. Even with the experience of my 2000 strictures, 2001, I failed miserably in fixing up a very simple end-to-end anastomosis. You put an artery clamp with all your experience for dissection, what would be the response of the surgical scene? Nobody can predict. We work under highly stressed circumstances. And that's why all this, one word you remember, that all we are trying to do is bring more predictability and empower surgeon, which he can know, not as act as an astrologer, but in order to take remedial actions. And for that, part of the presentation would be on cognitive surgical guidance. Here I'll clarify, we have reference guidance. We used to write from age immemorial, we'll put IVPs and keep on plying between the patient and the x-rays even now to make sure that every stone has been removed. Similarly, we have advanced version Tile Pro, but it is not immersive. It is not at the surgical site. It is a reference guidance. And we are working towards providing you something integrated with your surgical scene. Democratization of excellence. It was a real privilege of life to work with Dr. Menon, who is the epitome of excellence in everything. But let me tell you, I often have discussions with him. He has an experience of 10,000 prostatectomies, but word over, there are millions of prostatectomies. And when you compare collated experience with million prostatectomies, his experience become a babe. And previously it was not possible to humanly transport Dr. Menon like people everywhere. But now it is possible to bring in their best practices and blunt the learning curves. I have my own views about the learning curve, which I'll probably allude somewhere, because learning curve is a fallacious thing that 10 cases, 20 cases, 30 cases, it doesn't work that way because each procedure would have 10 learning curves. There is a learning curve for immediate recovery of the prostate, radical prostatectomy. There is learning curve for 30 days. There is learning curve for functional outcomes. So learning curves are only proposed deceptively. Since we are talking about artificial intelligence, many of you would be traveling with me on a totally unknown territory. So it may be in fitness of things to explain a little bit of what is artificial intelligence, wherein there is nothing. Human intelligence is replicated by computers with two extra skills. They are speedy. And number two is that they learn much faster than human beings. And that's why we apply them for problem-solving approaches. Supervised learning is where we have a ground truth model. We have a model and which we use for further data, and then you don't have to prepare a model for these cases. So that is a supervised learning. Unsupervised learning is what you call when you prepare a ground truth, and then computer system create their own output categories beyond the structure. Deep learning is a multiple layered hidden learning, which you will see some of them, which is done for computer vision, and it is known as layered neurons and the hidden nodes. And reinforcement learning is very interesting. Reinforcement learning proves the point what I told you, that computer learns faster. I'll give one example that DARPA came up with a robot, which it was a competition that there were 4 steps to open a lock. One is to hold it, second to hold the key, put the key in, and turn the key off. And all 4 robots were trained for different functions. But sooner they found that even the robot which was not trained for B function was able to do that function. So that is the power of computers. Algorithms, these terms we use, but algorithms are nothing but unambiguous specifications of how to solve a particular problem. Models are machine learning algorithms has been trained on a data. There is a training data set, and then there is a what you call the validating data set or test data set. And this can be used for making predictions. Supervised learning we have talked about, unsupervised learning we have talked about. These are the terms which are interchangeably used, but when you go to the technical segment of people, they are very finical about these terminologies. And machine learning is a natural language processing and language translation. It is a speech which falls in between text-to-speech conversation, which you know. And then robotics comes into deep learning, where you see industrial robots and consumer task robots work on that. And reinforced learning is the image recognition or computer vision work, where most of our work lies. Now, there is a change scenario. This is a growth from open to what you call current minimally invasive surgery. Open surgery, we had very limited preoperative demographic information of the patient, and we had an excuse that limited data, some investigations. Take urology, only IVP was the last word investigation we had before CT era. So there was no data for us, and we used to use that knowledge and do that. But now you see, with minimally invasive surgery, there is a huge amount of data generated by, you have videos, you can record the physiological parameters and all. And that is why this is an age where you have to exploit the availability of data for improving the patient outcomes. Why I am not able to go further. Now, surgical decision making, all of you are surgeons. It is simple for me to say is very complex, high stake, under time constraints and uncertainty, which has a significant impact on patient outcomes. You see, there is much talked about the safety and automatic cars, but human life, and this is not for patching up or avoiding an inquiry if a patient dies on table. It keeps on haunting surgeons for the rest of their life. Today, I remember the deaths which happened, which I feel could have been averted. So it is for personal reasons you have to see how could you improve the predictability in medicine. It's okay, we have told patient that your chances of survival after these operations are meager, but then it gives opportunity for patients to take a decision whether they would like to live with the problem, and it absolves you because you know about it that this was a possibility or a strong probability. Dominated by decisions are dominated hypothetical on and deductive reasoning, experience dependent. I don't like about surgery is experience dependent, and I'll repeat my great mentor and teacher, Professor, but any resident using in my experience, he would always stop him there and say, what is your experience? 5 cases, 10 cases, 20 cases. Here we say to tell our juniors, oh, you talk theoretical. In my experience, that I don't think exists in today's world, leading to biases, errors, and preventable harms. Framing, there are biases, you name them: framing bias, overconfidence bias, commission bias, anchor bias, recall bias, and confirmation bias. You name a thing and there are biases, and mind you, all of them are leading to likely harm to the patient. This I quote here, Ray Kurzweil, who was director of engineering at Google. 21st century is fascinating. It wouldn't live numerical 100 years, but it would have an output of 20,000 years of progress. Would you know that's surprising that with all the powers that computers have leashed, they cannot match the learning power of a toddler? This is truth. But they are very fast. Humans can communicate with each other at 10 bits per second. But computers, a series of computers or parallel computing can net the speed of 100 million times faster. Now, why technology? Why are we talking about this emotional issue of what you call predictability? It's not necessary. We can still work. No, these are the facts. Preventable surgical errors are third leading cause of death after heart attack and cancer. If this is true, where the data is so meticulously preserved by multiple agencies in United States, anybody's guess what it would be in India. 400,000 deaths due to complications every year, mind you, happening in United States due to avoidable complications. And this is Todd Ushan's, I'm quoting. This is Gary Goodhart in one of the webinars, which I recorded. 36%, Gary Goodhart is the chairman of CEO of the Intuitive Surgical. 36% of surgeries, according to their data, did not go as planned. Means there were events within the surgery and 1 in 10 patient did not recover. It was a lasting, durable damage to the patient. To set the workflow, we need 60 to 70 people to have a perfect workflow. Now you can imagine the state of manpower we have. Lowest quartile surgeons have 3 times more complications. Indirectly, among surgical fraternity, we have to know that 30%, at least pessimistic guess, 30% patients are dying in the hands of mediocre surgeons or learning surgeons. Isn't it enough cause for us to explore it further? Now, when you see surgical errors, if they take 100% as a total, I mean, say the number, then 25% are technical errors and 75% of them are human errors in decision-making, communication, team failure, and leadership. Now, that's where my focus is, because according to me, human errors can be averted to great extent if we leverage technology for that. This is another interesting thing. I was asking while labeling one of the transplant surgeons that how many times you see a lumbar vein during kidney surgery or live donor nephrectomy. And he was honest in telling only when I injure, I say probably it was lumbar. So we surgeon can fix up anything, any event. We don't let the patient die easily. But we believe in restorative surgery. And what I'm talking about is a predictive surgery where you know what you are going to deal with the next step. And that's where the technology will play a powerful role. I will tell you my journey started in 2018. And since then, we have had several projects. I started my project with one question we wanted to answer was surgical bleed detection. Because I thought there is a lag between when you see the blood and when the activity has begun. Can we do that? Fortunately, in 3 years, this project has gone from strength to strength. We have learned a lot. And the credit is to Mustafa and Abhilash Pandya from Wayne State University. They were the collaborators. I was PhD guide to Ms. Mustafa. And what we came out with was very interesting. This is one of the lobectomy being done robotically. And such scenes for experienced surgeons are not uncommon when everything happens without any notice. Now, I wanted to know in this read out situation, 3 things instantly go to my mind as a surgeon. Where the bleeding is from, what is the magnitude of trauma? Can I sacrifice that or put a clamp and be done with, or I have to repair it? Is this a venous arterial or venous and arterial bleeding? And that we try to do that for this. This is another thing. Watch this clip very carefully, how inadvertently bleeding takes place. Surgeon is a very meticulously dissecting and surgical target. There is, and I would give him 100% marks for his gentle dissection. You see there is a vessel, he's saving it. And there is a vessel on your left side you see which was getting tense. It may evade one's vision because it's temporal. Now you see the fun which happens. So there was a lag period when the event could have taken place and it took place. No big deal. You controlled it restoratively. But I am looking at how could he have prevented and developed a warning system that this would not have happened. So I would like to take you into, we created an algorithm and what we went on was entropy. We said that the entropy of the movement, entropy is the molecular arrangement of a structure at rest, which keeps on changing with the activity on that. And in entropy, you see on the left side, on the right side, the white patches you see is the instrument entropy, and the red is the blood entropy. And we did about 10 cases for his thesis, and he analyzed and he said there is a significant gap between the warning signal, and mind you, computers take no time. So we are ultimately proposing that we may give a computer tool which would give, there is no time for surgeon to process it, but it would put a guard on the robot that, hey guy, you are going to injure an injury, be careful with your traction. Now, that being said, these are very preliminary results. And then we found after this research that only giving a bleeding is not helpful. We need to find a context for the bleeding, where this bleeding is coming for. And that's why the major part of our research work on computer work. Predictive models. Again, this was an area which we started working on in 2019. And I had put up with my colleague a conceptual work when we had not done any predictive modeling. I had proposed a personalized predictive model with big data and published in British Journal of Urology. And we gave a schema of that, theoretical schema, that how the data would be collected, how it could be data engineered and model built. And we didn't talk about one thing, which was a lacuna in our vision at that time, that the predictive modeling is only exciting for editors to accept it until you can deploy these models through a feedback loop, use them in clinic on actual patients, and make them into clinical practice tools. Subsequently, we learned our next step and we published another paper. Because we didn't have access to so-called big data, you will have a feel of what big data is. And we had a mimic database, which was publicly available. You have to qualify by passing certain questionnaires and exam. And we had access to this data and we built this model. And this database, this is big database, which I'll tell you, 35,000 ICU admission, 8,064 ICU admissions of test data. And then we built a model on chart events only of 3.5 million chart events. And then we compared it by all-inclusive data, which was 15 million data points. And what we wanted to predict was 7 days mortality in ICU. 92% the model performed very well. This improved further by when we added more data. 4% more, which is statistically significant, model performed well. We were excited that we have made it, but suddenly we realized that the data which we had from the Mimic 3, we had no access to those patients. They were collected data from a group of hospitals, and we were not able to deploy the model. And then we started looking for our next destination to look for data wherein we can deploy the data and see the benefit of that data for the subsequent patients. And fortunately, we run a Vatikutti collaborative collective initiative, and you see a lot of Indian centers are participating in that for partial nephrectomy, and we collected this data and we did that. We built a model. I would not like to bog you, but the model perform area under the ROC was 87%, which is damn good. And precision recall was also very high. These are intraoperative events and these are postoperative events. Now, see the beauty of this model, how sensitive it is. We were very excited. My colleagues were very happy to deploy that model, and we were about to put that model into cloud. So moment that data comes in, it will give, when you are seeing a patient in clinic, it will give you what you call a warning signal that what are probabilities of his having intraoperative complication. And then in the meantime, after we published this paper, we had what you call 400 cases data. And we added the model, hoping that model will improve. And you'll be amazed to know model collapsed. Then we wasted a lot of time in this period of depression to see why model collapsed. It collapsed because the data changed. One of the major centers, Henry Ford, stopped giving the data. And moment the phenotype or genotype of, we didn't have genotypic data, but changes, the model collapses. Now, we know that what kind of things we have to do. So this is where we are. And now we are working, being wiser from these 3 milestones. We are working with Medanta on predicting acute rejection, first rejection of kidney by collecting data. They have a very well-maintained database of 3,300 cases, which my model builders say is minuscule. And we build the models, and models are, because these models are data hungry. We are talking of millions of data points. And now we have gone to modify that research project by trying to take UNOS data, which is a beautiful data, and which is mandatory for every transplant center in US to contribute data, and we'll see that. Now let us go into answering a question. Everybody said, when would be I faced this question, when would be the next automatic robot would come? And I did invited review way back in 2020 on current opinion in urology. And there we analyzed and we said, and my answer in conclusion was, don't ask this question to technology people. Technology is already there. You see, when the algorithms can work on autonomous cars and gaming and business intelligence, why wouldn't they work on human beings? It is not going to happen till we as clinicians adopt it and understand and participate in it. We'll see that. Then we were running for all publicly available data, and we had the CT segmentation. So we had a data from University of Minnesota, and we built the model where you see the CT, and this is the tumor, and this is the inference and ground truth. So we can do CT segmentation. We will show you video segmentation and things like that. What is the data characteristic we are talking? It's not the volume. That is the misnomer, that larger the data set, the better it is. It is a variety. Variety means the variety of data means there are more and more variables close to the probability of one are in that data set, velocity. With what speed the data coming in. That's why ICU data is much better, where you can predict time to event, because you know that blood pressure is taken every 15 minutes. Unfortunately, in urologists are very cursory like other surgeons, and we just look at the gross data points, and we don't have a culture, which Shivam alluded in his preamble, of capturing whatever we do, variability or consistency over time, veracity. Now, this last 2 points are very important. Veracity means you are talking of data sets, but you have to go to the origin. Are they reliable? Everybody talks of blood loss. No editor questions how the blood loss was calculated. Always anesthetists measure the bottle and all. So it is very important that what your models will collapse if your data is not trustworthy. Because it's no nonsense. Computers would not do any concessions. They will fail. And then comes the value of the data. It's a garb in, garb out. More data put in models is not going to put in. You have to put your hand. And that's why, to my mind, the questions of computers taking humans or artificial taking humans is non-existence. Because what you have is ultimately the human sitting at the top, and computers per se would not do anything. So it's complementary role. It is not competitive at all. Then comes, we talked so much about the data. So when we wanted to begin our computer vision work, the first challenge we have was to deal with different regulatory on databases. And like US has HIPAA, the Europe has very strict GDPR, India has, and everybody has a red herring. No ethical committee gives clearance till for a data to be migrated outside. And that's why we solve this problem by creating a ground truth factory, which we are using. And that ground truth factory is a democratic system of data sharing. It is not industry versus anything. Any center who shares the data has equal right on the data. He has control over the data. He can join from one project, and like these are 3 health systems we are talking about. And then there is a secrecy zone here, confidentiality zone, where at single station, the data is processed from dumped videos, uploaded videos to the model building. Now, this can be done in your own servers. We don't have to do it here. It can be done by your own people there. We are providing you with a platform, whether you permit or not. And that's where we had a very minor effort, very beginning effort on this. And we have started doing 25 videos from 5 centers for the live donor nephrectomy work I'll show you. 25 centers contributed and they control it. And very soon we are going to take away the administrative function by blinking blockchain or distributed ledger system where no permissions are needed, pre-written rules. You decide whether, like, if there is a commercial gain after we build the models, you know how much is your share. And this is what is the groundbreaking thing as I see. Then we come to surgical scene segmentation. Surgical scene segmentation is like face segmentation, where you identify different structures. And what we have is we have to build a pipeline. So we take these 5 raw videos, and then they put through a process of curation. And then these videos are annotated by a group of surgeons. Then there has to be a consensus in annotation. There is a post-processing of cleaning data before the models are built. So this whole pipeline can be done on ReadyMind's Ground Truth Factory, which was our own custom designed portal. And anybody is free who has an inclination. And let me make it very clear, we are data hungry, but we are very ethical. Until they are cleared by our ethical committees and we follow the country's rule, we will not accept the data. Our journey went in further in 2018, and this MICAI is one of the largest computer imaging conferences in the world. It's something like AUA or Urology Society of India for us in India. And we participated in that, and within few months of it, we had participated in a challenge where they gave us the data to identify what you call 11 objects of the porcine kidney. And we built that model. We didn't win this competition out of 11. They gave us 2,235 frames with 14 sequences. We could not identify more than 8 objects. But however, that was a learning experience and preparation for MICAI. And this is how the models performed. You see, this is the real video, and this is what the model has read, which is absolutely identical. If there are clips, it identified clips. If there are sutures, it identified sutures and things like that. Let me tell you why I am trying to convince you that labeling of data and accurate labeling of the data is the central piece of building any high-performing model. And that is in the domain of domain knowledge experts. It cannot be done by crowdsourcing. It cannot be done on paid basis by anybody else. Like cards, it is easy. Anybody can do the data labeling, but not for the medical purposes. It is very hard. We will see that. This is another model of how exactly, this is on your right side is the model performing, and left side is the real operation. Then comes the question. I will give you a quiz. What is this? Can anybody guess it? We participated in another challenge, and that was depth perception. Computers need depth perception. This is surface of the kidney. And we participated in exactly after 1 year on another challenge in 2019 one, and we won this challenge at Shenzhen. This was just before, in October, we were there before this whole thing of COVID started. And this is what would be needed, because if depth perception is very important for computer to do that. Now, labeling, as I told you, is labeling. This is what is to be done. And one observation we have made, that our anatomy is very different than even McGregor's surgical anatomy or whatever we have read. According to my experience, I am subject to correction by some of the excellent theoreticians as well as surgeons. But in my mind, there are only two things I know. One, I can afford to sacrifice. Another, I have to preserve. If you ask me, after having done so many live donor nephrectomies, that how many tributaries or which tributary of the gonadal vein is this, I have no answer. Which lumbar it is, I don't have to know about all that. So our knowledge is very clear, but mind you, when you are dealing with computers, you have to be very specific of what you are labeling if you want to expect what you expect model to do that. And here are certain things to tell you in our intersection over union is what you call that, what exact location of the structure is and how the annotator is located. Now, this IOU is a statistical term we use for a correct labeling, and is 80% if the labeling is correct, which drops down to 47% if one annotation has been like this and another is totally different. And it drops down further to 0.221 for renal vein. So labeling is very important, very challenging. After we build the model, the whole journey would be that we build these models. Then we want to personalize these models with computer CTs of these patients done a day before, so that the model is corrected like your Tesla corrects the generic model with your driving style. Similarly, we have to do that. And the next are very crucial steps, which we are struggling to finance. And not only this is truly cutting edge, wherever I meet this fraternity of the people, first thing they ask is, have you been able to go beyond computer vision model building? Can you register? Register is, can you superimpose your virtual model over the real-time thing? And kidney becomes difficult because what happens that there is a movements of the kidney and there is a change in mass of the kidney with every action of the surgeon. So this is what you have, a liver model which has been superimposed over that, and it has to work in real time. Only 2 registrations have worked, or tracking have worked. The next step would be tracking. You can see what is tracking here, that I can superimpose, this technology is there, but it doesn't help me because it is something, it is not merging, it is not immersive. And that's where what you call the tracking has worked only in 2 robots. Is wherever there are bones, like joint replacement robot, measure brain robot, because then these are fixed land points and we can put pins or markers on bones, but unfortunately we can't do it for kidney. We have been working, and maybe in subsequent lecture I'll be able to reveal. Currently it is a cutting edge thing and I am bound by the confidentiality, so I won't be able to give you details, but we are very close to trying to register the organs. This is yesterday, and I was excited. I went to my lab yesterday in my office, and we have several groups working on these problems, and they have been able to use slicers for doing the CT scan of the patient. And you have it's virtual reality thing where I can play with the organs and I can pull out the kidney, I can pull out the stone, and I can do that. And so far, we had the company Google provided models, but first time we have used a real-time CD to make this to happen. And these models are everywhere in the room. You can make them big, and it is now the challenge is this is virtual reality.
Yeah, I think we got to think.
Hello, sorry.
So please continue. There was some disturbance probably. Please.
Okay, I thought it's a siren for me. So that is a virtual reality, and all we want to do is real time give surgeon an immersive interface either at the site or in the monitor, where surgeon is guided by robotic tools which hold you. I'll tell you at the end what it is. Number one, when we are talking of big data, data feeding is out of mind. You have to have automation where you can capture parallel what is happening. And Chinese have produced a beautiful paper on trying to predict complication, intraoperative hazard in a surgery by face reading the people in the operating room. And that kind of cutting edge work is going on. So we have to create a mechanism, whatever is happening is captured without anybody keep punching the data. We have talked about this. Now, I think this is the era where there are lots of biosensors, and we have been in touch with a biosensor expert, where these physiological sensors which would be absorbed, which would collect a lot of physiological data on blood flow, pH, and things. And so surgeons need to go beyond 5 or 7 data points of console time, operating time, which doesn't mean anything. You have to think whatever you are doing, is it worthwhile or not? And I think surgeons have to have a wake-up call that you have to collect what you do if you really want to step in that field. Now, I want to show you, I don't personally am very excited about having an automated or second generation robot, but what I'm excited about this kind of example, well, when you have standalone tools, which will help you to improve the patient outcomes. 1.7 million high-risk abdominal surgeries are done in US. Leak accounts for 13,000 deaths. Real-time detection of leaks, pH and bacteria level biomarkers, and session response is 100 times millisecond. This is a small company, and this is the CEO. It's a very small company. So don't look at very big giants in Silicon Valley is on the verge of decimating to some new culture where we have a lot of startup and bright young people working in these areas. And this is a company hardly 5 people do. And what they have produced, you see that. This is the surgery has been done. This is the patient. He has the first drop of leak, mind you, even before the pain, which is the beginning of cascade of events. And there is a sensor placed there. His cell phone gets, go and see your doctor. At the same time, doctor gets a message. And this is the true definition of how can a stitch prevent many. Now, I am at the close of my formal talk. If I could transmit one message to you, one message which is very generic, unrelated to talk, and that is learn to live with unknown. Try to leave your comfort zones. Don't be scared of unknown or what you don't know, because the treasure lies not only in harping on what you know, but to know what you don't know. I once again thank you. And I'll be very happy to answer any questions now and later on. Feel free to communicate with me. And once again, I thank you, Shivam and Dr. Menon, for honoring me with this unique opportunity.
Thank you, sir. Thank you. It was really very interesting and wonderful to know your passion about learning, about digital technology, and at this phase of your life, that is very heartening. And we know that digital technology and the improvement can definitely help us to improve our surgical technique, reduce the complications, reduce morbidity and mortality. So that is definitely there. But there is one query from my side, that technology is definitely can help us to improvise, but there could be some negative side of technology also. That is too much dependence on technology. I remember I come from a state called I state West Bengal, where Dr. B.C. Roy was born, and he is known for his clinical skill in a way that whenever the patient used to come in his office, he would give the diagnosis. And at that time, there was no technology at all. So, what do you say that are we, with the improvement in technology, are we losing the human touch, the clinical skill, and the acumen? That probably is equally important. So,
I
your take.
think you hit a nail right in the head, Shivam, and it is very true. Let me address BC Rai's thing. The true story is Dr. BC Rai had 6 MRCPs working with him. So it would not be a hunch diagnosis. It is something like I or you used to process cases for Dr. Gangwal and Dr. Gangwal. This happens all over, but definitely was one of the brilliant physicians and clinical science people India has produced. Two things come up, which I would like you to say. Technology is created by human beings and used by human beings. So if anybody is to be blamed for misuse of technology, like today, it's a plastic card or what you call the money transfer things are there, but the frauds are also there. That is humans need to be blamed. I'm not for curbing technology because there is a possible harm, but there should be ways because they will be all parallel. What you say is so right. The third point is the human element of medicine needs to be kept alive. And that's why I say that there has to be a right balance between Indian medicine of where there is nothing in villages except for consolation and common sense of the physician and highly technical institutions. Yes, technology with the present speed is already dying the human side of medicine. Now nobody uses stethoscope. You remember our MBBS exam would be dependent totally on whether it is a cavity or consolidation or a collapse or three existing together. Now, you ask anybody, in the first thing, even in pulmonary medicine, is that get a CT scan done. So definitely it has revolutionized. There is the data to say it hasn't made an impact. But my argument is as long as we'll have to have a bullock cart age as well as Chandrayaan, we will have to keep the human side of the medicine. And it's not the disease which bothers the patient. It is his psyche. It is the human side, how you talk to him, how much you are able to console him. I think this is very pertinent that as technologies grows, we have to be more aware of the human side of medicine.
Right, sir. Another negative side, what I feel perceive is like sometimes when you go to the banks today, which are totally computerized, and then the net fails, and there's a total crash, and then you cannot do any work. The whole bank comes to a standstill. So, do you perceive this kind of situation in the future, that if the technology fails or if there is a crisis and then we are all at a standstill, we don't know what to do then? So,
I,
too much
I,
dependence on
I
technology
think I'll
can
give you my
create.
own yeah, sorry, go ahead. Sorry.
Yes, please. Yes.
I'll give you my own example. Sanjay Gandhi was the first institute in the country which went totally online way back in 97, 97, 98, 99, sometime. And this question was asked to me by the CDEC people, that how much manual system you want. And believe me, it was my decision that I don't want any manual system. All these probabilities was posed to me. The system may crash. I said, that is your challenge. Make the system robust, buy the best hardware, have the backup mechanism, but I don't want it. And within 3 months, I had a taste of it. There were 200 patients waiting outside, wanting to get in my office because the system had crashed. There was no way for us to collect money and discharge these patients. But from there, we created parallel systems. And similarly, you saw about a year ago when COVID started, Zoom collapsed. We had a webinar and it didn't work. So what I would like to say, that yes, you have to have backup mechanisms, but you would be persuaded to have backup mechanism. This is my approach. If you really give them a total trial rather than having a backup, sometime I can ride on this, sometime I can ride on this. So definitely technology has flip side. That technology will be, even now we fail in Zoom communication. Many webinars go blank because there was technical failure. So that always, these are flip sides of technology.
All right, sir. So yesterday we had a class on this radical cystectomy, and we were just discussing about how the newer centers and institutes are picking up laparoscopy and robotic surgery. And maybe in the near future, most of these centers will be totally working on robotic surgery. So do you think that this will, because there may be times then when the robots do not work, or then you may fall into some kind of complications, and then you might have to do an open surgery. And as trainees, maybe in the near future, their residents would not be able to do an open surgery. And because they are so much dependent on robotic or laparoscopic surgery. So do you think this kind of situation or problem can arise in the future because of too much dependence on robotic surgery and laparoscopy and no training of open surgery?
You take some of us, like I see Dr. Bhatyal being here, and some senior urologists back to 70s, when transurethral was the only trump card with the urologists. And this argument was brought in not only by general surgeons, by urologists. I do open because I have to teach my residents there. So what you say is very right, but take Henry Ford. Till Dr. Menon was there, 80% of the surgery was, besides the point, their case mix is different, was robotic. Even the colonic leaks would be handled robotically. So there is a generation of urologists who don't have that much of open surgical experience, but they work on a collective wisdom. Because here the regulatory, here in India is totally different. Regulatory is, even if I'm confident of dealing something outside my discipline, regulatory wise, I have to call the specialist. It's no big deal. I open something for pyonephrosis, and many times I found empyema gallbladder, did a cholecystectomy with surgical background. But here, you have to have somebody. If there is a vascular injury, you have to call the vascular surgeon. But it's very true. And I would take this argument not at the policy level, but at the level of fellowship and resident train. Residents should prepare themselves and make sure that they have an evenly balanced experience in open endoscopy and laparoscopy surgery, and if opportunity, robotic surgery. Because best specialist I choose is the one not who criticizes the modality which he doesn't have any idea about it, but he does everything well and picks up a modality what is needed for that situation.
All right. So I think the open, it should be a balance between the two, and the open should not be totally discarded. And we should
Absolutely.
keep on probably doing open surgery also, and the residents should also be trained a little in the open surgery before they embark on the robotics.
Yes. Now,
I
I'll
would,
ask a counter question.
yeah,
We had done Dr. Gangwal's anterior incisions and opening kidneys and so much open surgery we used to do.
right.
Now, how much open surgery you do now at SMS for stones?
No, definitely, very, very, very little. No
That's
doubt.
what I
But yeah,
said. That argument was there. We used to justify there, oh, this is a total staghorn. I want to have a complete clearance. So arguments and logic is such an enemy of human beings. We explain anything and everything by something, which
yeah.
changes with the time. So that's what I say. There are enough examples and nature will take care of it. Only thing is you have to focus on the patient. Patient never comes with your decision that you do a percutaneous or lithotripsy or whatever it is. He comes with a very simple deal. I have a stone, remove it. Now,
Right.
if you bungle by doing something and then telling it didn't work and then I am doing this. So I think the things are very clear. If you keep a very clear head on, ultimately you are working for the patient. And anything and any bias, you would not let it come till really it is a situation where you yourself are not certain.
But we are really fortunate that we are equally trained in open surgery also. The first 10, 15 years, we did so much of open surgery, and now we are doing endoscopic. There are times, one or two cases like this, when we have to actually open the case and do an open surgery, and we do not have any problem. But maybe the newer residents may have problem if they are not trained. That was my just take on that. So if I would invite other faculty members also to please join us. And if you have any questions or any comments, please let us know or put them in the chat box. Yes, I can see Dr. Anil Ellens unmuting himself. Dr. Anil Ellens, you're most welcome.
Hey, Anil.
Yes.
Hi, good evening, sir. Greetings from Meerut.
Thank you.
As always, mind blowing, and it is a sense of deja vu. I go back to 1990 when I stepped into SGPGI, and you took us out of our comfort zone by introducing us to computers. I still remember the DOS commands and the computers, and you didn't let the office boy or the office clerk do any of our presentations. You forced us to get onto the computers, made us do our presentations, and I still remember those days. And about 3 decades later, I see myself at the same place and you at the same place. You are leading us even further into the future. And this was a truly mind-blowing talk you had. It opened up so many avenues. My one a thing which I feel, I mean, you are leading, you are at the cutting edge, but I feel as part of our training, we should be made very conscious of the fact of data collection, and as you rightly mentioned, valid data collection, trustworthy with data collection, and how to validate. And it should be part of our surgical procedures where data is probably noted and collected as part of the surgical procedure. We shouldn't just do the surgery and walk away. That would probably lead us to what you are building, this huge database which would help future generations. So I feel data production should be so automated that we don't have to make an effort of finding it.
Thank you, Anil. It has become almost a personal meeting because next I see is Madan going to talk. So what, Anil, I think I'll demolish one myth, which you remember when you were resident, we used to talk that I don't discriminate between academic centers and the private and a solo practitioner.
Correct.
My take is that anybody who touches patient has to audit for himself. It is no research. All of us do. But we do sloppily. We go by anecdotal things. I had operated so and so in Muzaffarnagar and he did well. All I am trying to tell you, because whatever you say will happen. Resources are no problem for you people. If you feel the need for doing it, all you do, because I remember a visiting professor, he says that I just keep on doing that. I have a clinic of 100 patients, and I will prepare questionnaires when they are waiting. I'll give it to them. Please, if you don't mind, fill these and a consent form. And at the end of 5 clinics, I have a survey and paper published. So what I'm trying to say, it is not the means to do data. It is feeling the awareness that there is need of a data. And that's why the saying is, whatever you do should be captured. And now there is a technology, what you say, that surgeon can either focus, or you can say, no, I'm first surgeon, so I'll not do it, let my assistant do it. Assistant has a job to do. Nurse has a job to do. Data feeding person has no idea of distance between two his armpits. So what is he going to do? So only thing can do is technology, where you set up system, everything happens, and then it would be honest to you. You wouldn't be able to erase out if there were 5 liters of blood loss. It is 5 liters corroborated by so many units of blood issued by the blood bank. So it is developed, and the challenge is for, because Shivam, I would like to not upset, but most of the focus when we were there was a race in having that I must have a robot, I must have upper track, I must have mini scopes. That race should be changed into function. That race should be changed into that, well, I have a best patient management system which doesn't need resources, it needs thinking and commitment of the people.
Right.
Dr. Madan, Dr. M.M. Bansal is there. He raised his hand. So, Dr. Bansal, you please unmute yourself and come in.
Show your photo, Madan, how old you are. I want to compare.
Dr. Bansal.
Was over 70 now.
Over 70?
Yeah, and
so put your video on, please. Dr. Bansal, put your video on. You can put your video on.
Yeah, okay. Yes, sir.
Hello, Madan. How are you?
Boss, looking at you after a long time.
Yes.
I am not going to talk about anything digital, non-digital, this, that. I have hundreds of memories with you, like our elder brother in the department when the department was coming, and the department was the whole family. And there was so much we learned from you. So those memories, all there like it was the other day only. Thank you. My regards. My regards to Bhavi also.
Thank you so much.
Thank you, Dr. Bansal. We have Dr. Neeraj Agarwal from our department. He wants to join. Please, Dr. Neeraj, come in.
Hello, sir. Good evening, sir. Bhandari, sir. I am Dr. Neeraj. I am a professor in the Department of Urology here in SMS. And I must compliment you. I was really awestruck by your amazing presentation. It took me into the future of what the urology could be like in the next few years, sir. And only yesterday I was talking to my father-in-law, and he happens to be a very close friend of yours. If you recall, during your days in SMS, Dr. Nirmal Kasliwal. And
Nirmal and we practiced together for Trimurti Clinic.
I know that, sir. He was literally, I told him that we would be having your lecture.
Nirmal Kasliwal?
So he's my father-in-law, sir.
Yeah, he's captain, na? He was in army.
Yeah, sir. He was in army and he took retirement from army. Now he's practicing here.
How is he keeping? Good.
He's wonderful, sir. He's fine. And he asked me to convey his greetings to you, sir, when I told him that you will be joining us, sir.
Thank you very much. God bless you.
So, sir, my just comment or whatever my, small query was that you are fortunate enough to be, doing your research in a country where you are not short of any resources. You have the best of technology at your disposal. You have all those, financial support. But in India, I mean, do you expect us to achieve this type of research, especially if it is really, in India, we have so much of drawbacks and shortcomings. And I believe this type of work is only possible in a country like United States, sir. So what's your take on that, sir?
That is a myth, Neeraj. If one part of presentation which I would like you to think, which none of you would have noted, in all the papers, you didn't see the rainbow collaboration we are having. We work in Armenia with the people in Armenia. We work with people in Pakistan. We work in India. We work in Germany, Belgium. So what I'm trying to say, all it needs is your commitment. Don't think that these are resource intensive people. If you have a story to tell, there are people willing to invest in that. So don't underestimate the power of individual mind. Whenever there would be professors interview, they will say these means are not there in my department. But I always used to ask them and say, nothing prevents you from learning from enormous theoretical knowledge available on internet. So do your component, have a question, and resources will fly in. Don't think that they are high resource things. I spent 2 years from IIT to IIT wanting to collaborate for computer vision project. Standard answer, yes, we can do it, but we need resources and we need fellow. Till I found Madhu Reddy Boina, and he said that I have no resources. He was running a small IT company. He's running a small IT company. And he said, no, I want to move with you. And we both joined. He provided technical thing without asking for anything. And I provided my domain knowledge. From there, we were asked to involve in the Wayne State project. Then we participate in these competitions. We had the model building done all over. So I would say that don't lose your power with these excuses.
Right, sir. Clear, sir. Very encouraging words.
Thank you, sir. One more question from my side. You said about that, yes, the computer intelligence will never cross human intelligence. But what we are seeing and what is being happening now is the digital technology we know is growing exponentially. And it is almost now we have 12.3 billion transistors in a single chip. And what the Moore's law tells us that every year this is getting doubled. And we have almost 40 million documents that can be read by computer in a 15 seconds. And we don't know what will happen in the coming 15 or 20 years. Though there are kind of perception that, and we know that there's a term called singularity. There's a fiction, also a movie by the name of Singularity, which was given by Newman, who is father of cybernetics. And he was saying that by 2045, probably this computer intelligence will cross human intelligence. And the computers will start thinking by themselves. And that is the time when probably they will cross our intelligence, and it would be where the physical world and the virtual world would probably be very similar, and we would not be able to differentiate between the two. Do you think there is a possibility, the way in which the technology is advancing, there is a possibility that this will lead to this kind of situation?
Yes, it will. And I'll give you an example. Don't think that it's a competition. I told you before in my talk. Take Jeopardy, which beaten the best players. Why? Because there are 100 people sitting with 100 computers and all the knowledge. So what I'm trying to say, that the very fact, like why autonomous cars would not go 100% autonomous where you can sleep. Why? Because technology is there, but because the decision was made by the human beings. That ethical decisions which are complex for human beings also, that you are on a road driving a car and you have a tricky situation that a kid going here, 5 people going there, and the tree going on the third side. Now, there could be a human error and you'll kill. Same thing car will do. So car can't think beyond it. So what my argument is that, yes, these things will happen, but you will never be able to curb the growth of technology. See, computers have to perform. These people write algorithms, and that's why come to the front stage, because nobody can create a robot until you give them their videos, you give patient information, you annotate that data for them, you validate the model, you become a much more powerful. And that's why Neeraj's question I'll address. I always said in so many forums I talk in person and here that India is in the most powerful situation as far as the future robots are concerned or any automation in surgery, because we have excellent infrastructures, we have excellent technology working there, and huge volume of data. All we need to be smart is exactly the story of Serum Institute. Even if we wouldn't have innovated, but if we have a capacity of producing 70% of the vaccines of the world, we are anyway powerful. So don't underestimate the power of what you guys do and the data you produce and the quality of work you do. Only thing is translate into something which people will buy it, not only giving the countable example, they did excellent and things have improved a lot. I don't say that, but learn, tie up with, give another example of Chinese have 90% of papers after first wave of COVID. And they patched up their credibility issue by joining the best institutions. Their papers are with Oxford, their papers are with Harvard. Now, those are the kind of partnership. And these institutions would not publish in NEJM and JAMA until they have satisfied them with every bit of the data. So same thing Indians have to do. Take example of robotic kidney transplant. Every reviewer, we had to answer a question, why the hell you did it in India? We couldn't have said because US, nobody was willing to take it. But only data which established after one paper was there, no going back. Everybody used that reference. So you have to cross that bridge. And I would 100% agree with you, but you don't have to get scared with technology. You don't have to. It will find its own place.
Right, sir. You rightly said that, yes, India has a lot of potential. We know because most of the Indians who go to United States, they excel in all fields as the opportunity comes to them. So I think we have the skill, surgical skill, we have the amount of workload, we have the patients, the amount of number of patients that we are working on. Only thing is we need to, as you said, collect data, publish them, and then export and then express ourselves at the world platform. I think that is very important to help us progress in this field. If anybody of the faculty members or viewers have anything else to say or have any comment, I will just invite them before winding up the session. So thank you, sir. Thank you once again, Dr. Bhandari. It was wonderful because at the personal level and also because you were my examiner in the final MCH examination. And I also went to SGPGI, if you remember, for my pre-MCH interview. And you interviewed me there at SGPGI Lucknow. Unfortunately, I couldn't be your resident, but it was very nice to host you and Dr. Mani Menon. Definitely, both of you are living legends today, and it was a real proud moment and a historic moment for the Department of Urology SMS to have hosted you. Thank you, sir. Thank you very much.
It was my pleasure, Shivam, to talk to a very intense group of few people, and I'm always happy to talk to you because it's a nostalgia for me. SMS, where everything die was cast for me. Thank you very much.
Thank you, sir. And we definitely would like to be in touch with you, and we will ask our faculty and the residents to collaborate.
Anybody is most welcome, and I will not wince because I apply my emails all the times because I have luxury of time. And thank you.
Thank you, sir. Thank you very much. Thank you for spending your valuable time, sir. Thank you. Good night.